Hello, my name is Mr. Ishak. I'm one of the consultant spinal surgeons at the Royal Orthopaedic Hospital, and I'm here to talk to you about the examination of the spine. That'll include both the cervical spine and the lumbar spine. As with any orthopaedic joint, the basic principles of look, feel, move apply to the spine. So if we start with the cervical spine, on inspection, what you're looking for is you're seeing whether the patient has any abnormal posture or not with regard to their spine, whether they're holding their neck in a funny way. So straight away you can see that Sarah's holding her head up in the neutral position. Moving to the side, I'm looking to see whether Sarah is maintaining her cervical lordosis, which she is. Going on to palpation, the obvious places to palpate are the occiput to the vertebra prominens. Before you put your hands on any patient, obviously you've got to ask them whether they've got any pain. So have you got any pain, Sarah?
No.
No, wonderful. So again, feeling from the base of the occiput and down. Here you can feel that the cervical spine is really quite superficial, so you can actually feel the spine quite easily. Going on to move. With the movement of the cervical spine, I tend to stand in front of the patient because that's a really simple way of guiding the patient and telling them what you want them to do and how to do it if they don't understand it. So, starting, look straight at me, Sarah. If you could put your chin on your chest for me. And that's straightforward. Look back up at me again, look to the ceiling. Back to me again, look to the right, back to me, and to the left, and back to me. Now those are the basic ranges of movement. Then going on to lateral flexion, what I usually ask the patient to do is, could you touch your ear to your shoulder, and back to the neutral, and your ear to the shoulder on the other side. Lovely. So that's basically look, feel, move for the cervical spine. Now, any cervical spine examination has to include an examination of the upper limbs and the neurology, because when patients come to you, they basically either have neck pain with arm pain. Now, if they've got arm pain, you need to know where the pain goes down the arm. That basically gives you an idea of what nerve is being pressed on. And what you've basically got to do is you've got to try and make sure what the patient tells you is the same as what you're seeing on the picture in the MRI. If the two are the same, then there's a good chance if you do an operation, you can help them. Now, in order to do this, you have to know your dermatomes. The patient will tell you where the pain's going down the arm, and that will give you an indication. So, for example, if they had C6 nerve root pain, the pain would be going into the thumb and the index finger. Now, to quickly go over the dermatomes for you, you start with C4. C4 is the cape region. This is over the trapezius muscle. Going on to C5 is over the biceps. C6, as I mentioned earlier, is over the thumb and the index finger. C7 is the middle finger, and the pain would routinely go down in this distribution. C8 is the ulnar border of the hand. T1 is the posterior aspect of the upper arm, and if you remember, as we said, C4 was the cape area. That comes round the front the same way as a cape would, and T2 goes from the axilla across the front and joins so that you have the transition from C4 down to T2. All right? So, having an idea of the dermatomes is what you really need diagnostically. Now, going back to the examination, you're going back to look, feel, move. Inspection. So, in a neurological examination, the most obvious things that you're inspecting for are evidence of wasting or fasciculation, so which would be evidence of a lower motor neuron lesion. And you would see whether the patient had any obvious wasting in the arms or the hands. Next, I tend to test tone. Now, tone, I use supination and pronation of the forearm to see whether there's any evidence of increased tone, and similarly with the biceps. Power. Now, with regard to power, I always test like with like. So I always test my right arm against the patient's right arm. Again, if a patient is in pain, it makes sense to test a non-painful side first. What that does is, at first, is you're not hurting the patient, and secondly, you're teaching them what you want them to do when it comes to examining the painful side. And usually it's a lot more sensitive on that side and they know what you're going to do, so your chance of picking up the abnormal pathology is higher. So if we start with the right arm, now the other thing you're taught to do is you're taught to feel the muscle as you test it. So starting with biceps, C5, I can put my hands on the muscles and feel it. Pull me towards you. Now, while you're here, it makes sense to test triceps, which is C7. Push me away, and I can feel triceps. We then go to wrist extension. Cock your wrist up, keep it there. C6. Long finger flexors are C8. Remember, we've already tested triceps, C7. C8, long finger flexors. Then spread your fingers, T1, the small muscles of the hand. That was the normal side. Now going to the abnormal side, left hand to left hand. Going a little bit more quickly, you can see I pull me towards you, push me away, cock your wrist up, grip my fingers, spread your fingers. And there we go. So, that has done power. I would then test the reflexes. When I test the reflexes I'm testing are brachioradialis, biceps and triceps. Now, just striking the brachioradialis is often quite tender, so I tend to put 2 fingers over the brachioradialis tendon and then strike my own finger. Similarly, striking the biceps tendon is quite difficult. And what you can do is you place your thumb over the biceps tendon, you can feel it underneath your thumb, and then you strike your thumb. As the reflex fires off, you can feel the reflex under your thumb. And you saw the arm move there. With triceps, you're trying to strike the tendon as it enters into the olecranon. On this side again, 2 fingers over brachioradialis, index finger over the tendon, reflexes. Now, if you're looking for evidence of an upper motor neuron lesion in the cervical spine and you're worried about cord compression, then you're looking for things that would show evidence of myelopathy. So whether there was evidence of compression on the long tracts. Now, evidence of increased tone would be Hoffman's sign. Hoffman's sign is performed by flicking the middle finger and looking at the thumb. So if I flick the middle finger like this, I'm looking to see whether there's an involuntary flexion at the IP joint of the thumb. If there is, then the test is positive. Similarly, to see whether there is evidence of compression on the cord, you can test the long tracts within the cord with Romberg's test. Now, Romberg's test, basically, what I get the patient to do is stand up for me, Sarah. And you put your feet together, and now close your eyes. And you can see Sarah is swaying there. Now what she's doing is she's getting feedback from the pressure receptors on her feet, which are moving up the dorsal columns for proprioception, and then using that feedback, it's going down the motor pathway, down the efferent pathway, to correct her balance. You can open your eyes now. So that was negative. If she'd fallen, then you know that one part of the pathway is being affected and the test would be positive. You can sit down now. So that concludes the examination of the cervical spine and the upper limbs, including a neurological examination, and we'll now move on to the examination of the lumbar spine.